Now I would like to invite Dr. SONU GOEL for IOL power calculations in post-refractive eyes and keratoconus.
Very good morning to each one of us, and I'm extremely thankful, Dr. Twinkle Shah, for making me part of this course. And I think it's one of the few courses who have been repeated year after year. And thanks to the wonderful content that and the speakers Dr. Twinkle Shah has incorporated. So a quick question to all of you, the audience. So how many of you are into refractive practice? Any of you practice refractive? Yes. I see very few hands. And how many of you have those newer gadgets that Harshul had said, the optical biometers, access to optical biometers? Yeah, so I think yes, few of them. So what is more important is that when you get these extreme of the patients, long, short, post-refractive, I think these are real challenges. And even if you don't have an access, the best thing could be you can calibrate your own devices to suit those needs. And these are those tricky patients who would always give you refractive surprises. So the whole purpose of the course is to, embrace these extreme situations. So what I'll be talking is, the next 10 minutes is patients where you have post-LASIK, post-SMILE, post-RK, and post-keratoconus, and keratoconus patients, maybe they are cross-linked. So these are those bundle of patients where you actually need to evaluate and move forward for the calculations. We all know that now we have a high volume of refractive surgeries which are being performed worldwide. So we have a huge volume of these patients who have been coming to us. And moreover, refractive surprises lead to dissatisfaction, because these are those patients who got refractive surgery to have that 20/20 vision day one. And these patients, when taken after cataract, would always require or always expect the same quality of vision post-cataract surgery. So an accurate biometry is essential to attain the best or the visual outcomes in these subset of population. The major concerns in post-refractive eyes is basically the expectation, as I already told. There is a difficulty in the IOL calculation because of the multimodal problems. There are incision issues when you're dealing with post-RK eyes, because we have 4 cuts, 16 cuts, 18, 24 cuts, and extending near to the limbus. So these are those patients where we have to be extra careful, because otherwise the incisions start ripping off. There is issue of visual quality. Then there are difficulty in the IOL selection, because most of these patients would always need a kind of a presbyopic IOL correction, which is difficult in these subset of population. And definitely these are those patients who have been suffering from dry eye issues, maybe because of their post-refractive surgeries. So the IOL calculation requirements, as we all know, basically includes the excellent calculation. Now the central K, where I mean the anterior and the posterior K in all these patients. Now we have to take care of the surgically induced astigmatism, which we will be inducing. So there could be some amount of corneal or lenticular astigmatism in these patients, and ELP, or the effective lens position, is one very important key factor, which is the whole source of misery in these subset of population. Now, talking what are the errors actually we are talking about in these subset of population. So error number 1 is in the prior myopic LASIK patients is the radius error. So what I actually mean by radius errors is that when you do a refractive surgery, you calculate out what is the optical zone required. Sometimes you can end up with decentration and little islands where you have actually not ablated, or you have decentered the ablation, and there could be some central islands left, and whether you have done a wavefront optimized or customized treatment. So that all translates onto the cornea, and this is what ultimately leads to those refractive surprises. So how do you do it? Post-LASIK, the wide range of curvature within the central 3 mm zone is what is the concern. So you can have a larger optic zone. Sometimes patients have been treated with very, very small optic zone because of if you're treating high refractive errors, wavefront or standard ablations, decentration, as I said. So, and in keratoconus, you can miss the central flatter areas. The concern number 2, or the error in IOL power calculation number 2, is actually the keratometer that you're using basically works on the principle of a fixed ratio. So basically you have 1.3375, which is the ratio between the anterior and the posterior, and that's why you calculate out the curvature. But in myopia, what is actually happening is you're flattening the anterior corneal surface. And this is what alters the relationship between the anterior and the posterior corneal surface. So keratometers and topographers usually overestimate the corneal power, and it is basically around 1 diopter for every 7 diopters of refractive correction, and that is what translates into your hyperopic shift. So most of these patients, if you're just taking consideration of the anterior curvature, you will end up landing up in hyperopic shifts. So you have to have what Dr. Harshul pointed out, the newer devices which actually give you both the anterior and the posterior. So this could be Pentacam, which gives you a total or the true K or the net K, and then you can have Galilei or you can have IOL Master 700, which gives you the true K or the net K in most of these patients, which takes assumptions of both the posterior and the anterior. So the conventional keratometers, basically the corneal power calculated is at 3 millimeters, so average is between 2.8 to 3.7 millimeter zone, and it works on this assumption of the fixed anterior and the posterior corneal curvature, which we call as the Gould-Strand ratio. Now that is the alteration has been done once you have performed RK or myopic LASIK ablation in these patients. So the error number 3 in these is the error pertaining to the formula itself. Now what happens is when you are treating these 3rd generation formulas like Hoffa-Q, Holiday, SRKT, they work on basically calculating out the keratometric readings and the axial length, and that is what, based on that, they assume an anterior chamber depth and effective lens position. Now since there is an alteration in the anterior curvature, and that misleads to giving a effective lens position which is abnormal. So following LASIK, you can have low estimating. It is estimated that the IOL will sit more anteriorly, and this results in the calculation of a low power IOL. That means a hyperopic surprise. So at the end of the day, 1 millimeter error in the ELP corresponds to almost 1.5 diopter change in the final refraction. So in these eyes where you have done the myopic ablation, if the flattened post-operative corneal power is used to calculate out the ELP, the predicted ELP will be falsely shallow and result in the underestimation of the IOL power, and hence you get a refractive surprise. So this is one of the articles where they predicted the refractive prediction errors with the 3 formulas. If you see the Sharma's, Higgins L, and the Barrett K. So there is prediction errors, and there is a significant difference in the refractive prediction errors. And what is the solution to this now? So you need to actually measure or estimate the true corneal power, which we call it the net K or the true K, by applying objectively or by applying certain correction factors by the keratometry. And you have to use formulas which are not solely based on keratometry and axial length, and there are correction factors for accurate estimation of the effective lens position. So you can either have objectively means the total keratometry, the TK, which is available on the IOL Master 700. You can have applying correction factors for keratometry like the Pentacam EKR, and selecting, this is very important, the 4.5 millimeter zone, because that is what the pupil size for the normal Indian eyes is. And then you can have formulas which are not solely relying on the keratometry and axial length, and they add in correction factors for the accurate estimation of the ELP. So this could be the Holiday 2 and the Barrett's True K Universal 2. So these are the 2 formulas which actually take care of the ELP. So the conventional approach, you can have the pre-operative refractive data. If your patient has pre-LASIK or pre-RK refractive errors, the data, and you can use put these on the online calculators. You can go to the ASCRS or the ESRS website, and you can compare the various methods. So this is basically history versus no history methods. So a quick word of TK, though Harshul has covered this. So it's a very nice method of, telecentric keratometry and the swept source OCT. It measures actually the posterior corneal curvature, and it's incorporated in the IOL Master 700 with the latest software. And these 2 formulas, the Barrett TK Universal 2 and the Barrett TK Toric, have incorporated. So this is a quick description of what this 700 is. So it takes care of the posterior and the anterior, and it gives you, there is no reliance on the preoperative history. You actually don't need it, and you can objectively measure the actual values, and the newer generation IOL formulas work very nicely under this. So this is one beautiful article where, the intraocular lens calculation after refractive surgery, this was a long-term retrospective comparison of the 8 formulas. So if you happen to see here, again, the Barrett True K and the Barrett True K Net K works very well, and in all of these long-term, close to 3 months, if you see, almost bang on target. So one beautiful article which I just went through was this work done by Dr. Sri Ganesh on this, where he compared the performance in post-refractive surgeries, TK with Barrett's Universal 2, Pentacam EKR plus Holiday 2, Barrett's True K post-refractive surgery formulas. Now all of these formulas performed very well, and their estimation was almost less than 0.75. So total keratometry with Barrett TK2 provided comparatively predictable outcomes. So bang on target with all these formulas. A quick word of post-RK. RK actually changes both the anterior and the posterior K readings. So normally the corneal thickness remaining the same, but normally posterior to anterior is like -6, but RK actually changes both the anterior and the posterior. So you actually need to go and see the central flattened, the most flattened area in these RK patients. And what is more important is the scleral versus the corneal incisions, if you're taking into consideration. There could be some amount of diurnal variations in these patients, and there is usually hyperopic progression. So intentionally, you target a little myopia in these RK patients. A quick word with keratoconus, though it's again a different set of ball game. In keratoconus, there are, a lot of errors where you can end up. So, keratometry itself is difficult in these patients because actually the central K and K at different levels could be giving you a lot of variations, and which actually leads to sometimes overestimation, underestimation. So you can have hyperopic as well as myopic surprises with these keratogenic patients. So literature, SRKT or the Barrett Universal 2, and these two formulas, they are the still work good with keratoconus patients. So you have specifically designed IOL formulas for keratoconus, which really work well, and I think Barrett True K keratoconus is one which, though if you see in the next slide, they would not be really 100%, but yes, close to maybe 80 to 90%, that works well. So in these keratoconus patients, so estimating the corneal curvature, estimating the axial length is again a big issue in these keratoconus patients. So True KTK, post-myopic LASIK, and it was a multi-center study again done by Graham Barrett. So where they compared retrospective analysis of no history, and they found out the errors in predicted refraction, and they compared the True KTK versus True K on Hagees L, Hagees TK, and Sharma's. So they came out that the spherical power prediction with True K TK, if you see, the mean error was the minimum with this. So True K TK, I think, works very well. So to conclude, you can use the ASCRS online calculator, try to obtain pre-LASIK if you have the data. Barrett True K, I think, works very well. And ORA, in case if you are have an access intraoperatively, you can still, in the best of the hands is not available. And you can always, and you should always, discuss the difficulty and the chances of surprise with the patient, so that the patient doesn't come up the next day with some, filthy allegations, and always under promise, then over deliver. Thank you very much.